So Sarah is a consultant haematologist from Belfast City Hospital. She specialises in CLL, lymphoma and melanoma. And she's principal investigator. And this is one thing I've always really appreciated with the hematologist, the consultant hematologists that we deal with. They are inquiring minds. They are involved in research. Sometimes we see them in a face-to-face environment and they're in scrubs or in their civvies, but they do put on the white coat and they go into the lab and they're looking at our blood films. And I really appreciate this. It feels as if they're taking a personal interest in me as a person and a patient. So, and the fact that you're involved in trials as a principal investigator in a number of clinical trials at the Belfast City Hospital, and you've contributed to the development of national guidelines. So, Sarah, thank you for joining us today.
Good morning, everyone. I'd like to begin by thanking CLL Ireland and CLL's support for organising today's forum. Really delighted that it's in Belfast and it's a real pleasure to participate. So when looking at the agenda, I was mindful I was the first sort of clinical speaker today. So my session will hopefully give us a broad overview of CLL. I will begin by going back to basics and looking at lymphocytes and the immune system under healthy circumstances before discussing the diagnosis of CLL and some of the tests that many of you may have had to establish that diagnosis. I'd like to spend a bit of time discussing genetics in CLL. We'll look at why active surveillance is still important, and I know several of you are under active surveillance here today. But we'll also explore when is the right time to think about treatment and what those treatment options look like in 2025. We'll look at the different classes of drugs and then also look at some of the treatment strategies. I am mindful that some of you have been living with CLL for quite some time, so perhaps the first part of my talk might be something that you already know inside out, so forgive me if that is the case. But I also know that some of you, either in the room today or online, might have been diagnosed more recently, or perhaps you're the friend or a loved one of someone living with CLL. So I think it's important that we try to cater for all in the first sort of medical talk, I guess, today. So let's go back to basics. So whenever I meet someone with CLL or another blood disorder, blood cancer, I usually begin by describing the bone marrow as the factory that makes all our healthy blood cells. It makes red cells that carry oxygen around the body, it makes platelets that help our blood clot, and it obviously makes our white cells as well, of which there are 5 different types. And we're going to focus now on the lymphocytes. So lymphocytes are a form of white blood cell. While they develop in the bone marrow, they will circulate towards secondary lymph node tissues, that's the lymph nodes and the spleen. And there are 3 different types. The majority will be B cells, a smaller percentage will be T cells, and then we also have NK, natural killer cells. And lymphocytes are a crucial part of our immune system. And that's why if there's a disorder with our lymphocytes, that's why the immune system can obviously feel the effects of that. So both the B cells and the T cells will recognize foreign cells or pathogens, such as bacteria and viruses, and they'll respond in different ways. Under normal circumstances, our B cells should respond to these pathogens by producing antibodies, which can help neutralize bacteria and viruses, whereas the T cells can produce these chemicals called cytokines, which then can direct the immune response or produce toxic granules and enzymes that help destroy the pathogen or the infected cell. And our lymphatic system is just a massive body system. It's part of our circulatory system. So normally when blood is moved around the body, it leaks out into the tissues through little capillaries, and the majority of our blood should get back into the blood vessel. But what doesn't can get left behind as lymph. And this is a clear, colourless fluid. It comes from the Latin lympha, which means water. And it then makes its way back to the heart by these purple channels, these lymphatic channels. So you can see that our lymph node system, our lymphatic system, is this massive body system. These lymphatic channels bringing this clear fluid called lymph back to the heart. And along the way, it will pass through lymph nodes, which act as these sieves to help remove foreign pathogens. And in these lymph nodes, we have large concentrations of our lymphocytes. We have some 600 lymph node sites in our body. So you can see when we're talking about disorders which affect blood and the lymphatic system, they are whole body disorders and therefore can affect every part of your body. So let's focus in on CLL. So it is a disorder of the B cells. It is the commonest leukemia in the Western world. And for the vast majority of people, it should progress slowly. More common in men than women, And about 80% of people are diagnosed over the age of 60, but we've heard from Jan and Nikki that they were diagnosed at a much earlier stage. Certainly the youngest patient I've looked after has been 38. Some of you may hear the term SLL, small lymphocytic lymphoma, and that is when the condition is predominantly in the lymph nodes. CLL is obviously leukemia is referring to the blood, but for some people you might just see the disorder in the lymph nodes or perhaps the spleen. They're exactly the same sort of condition, it's just whereabouts in the body they are affecting you. So we've heard from Paul and Nikki today about how they've presented, and people can present in very different ways. It could be an incidental finding. So this year alone, I've had one chap diagnosed after being in a road traffic accident. He was otherwise asymptomatic and didn't know he had CLL until bloods were taken after an accident. Another chap this year who had an episode of cholecystitis, an infection in his gallbladder caused from gallstones, and when bloods were taken, we discovered that this gentleman had CLL. But for others, there may be some of the symptoms that we see here. And I noticed in Jan's slides earlier, one of the main issues that patients reported at the session last year was fatigue. And certainly fatigue is a big issue and a big clinical presentation. It may be lumps or bumps, some swollen glands. Some patients may have night sweats. I do find this is a less common symptom in some of my patients with CLL than some of my patients who have lymphoma, but they can certainly be there. If there's a large amount of CLL in your bone marrow, or if the CLL has caused your spleen to enlarge, you could have low blood counts. And if you have a low hemoglobin, you can be anemic. So you could be tired, short of breath and exertion, perhaps you may be pale. If your platelet count is low, you could have bruising or easy bleeding. Weight loss can be a feature, and as we've heard from some of our patients today, recurrent infections. It's very common to hear that patients pick up infections easily, they're harder to shake, or there can be a lot of infections in the months or years leading up to their diagnosis. So if we suspect CLL, we'll first of all look at your full blood picture. We will look at your blood film in the lab, and then we perform a test called flow cytometry, which I'll come on to explain in a second. We will look at the genetics of your CLL, and it's whether we do that at diagnosis or before you start treatment. There's different approaches to that. Some patients, if we're worried about swollen glands or swollen spleen, we will perform a CT at diagnosis or perhaps down the line as part of your journey. And in some people, you may need a lymph node biopsy, particularly if you have the SLL variant. Sometimes we do need bone marrow biopsies, less so in order to make the diagnosis, but sometimes it's in order to determine the burden of the disease. So we mentioned blood films, getting into the lab and having a look at your blood film. This might be what someone's blood looks like under the microscope if they have CLL. So we take a sample of your blood, it's smeared on a slide and looked at under the microscope. We see our red cells here, but you can see a large number of lymphocytes. These are small and mature cells. Unlike the types of acute leukemia where you have very immature blast type cells, these cells are quite small and they're quite mature. But when they're spread on the film, a lot of the cells can smear, and it's those arrows, those are called smear cells. The Americans tend to call them smudge cells. But this is a very characteristic finding, an increased number of lymphocytes and these smear cells when we're looking down the microscope. But that's not enough to diagnose CLL, and we do perform this test called flow cytometry. So CLL, like any other form of cancer, too much growth of one type of cell, one clone. And we know that the CLL cells will have characteristic little proteins or markers on the surface of their cell. And if I know what those are, if I can detect them, then I can be sure that the diagnosis is indeed CLL. So we take your blood, and with a cell suspension, we mix it in a test tube. And that cell suspension will have little antibodies. These will bind to the proteins on the surface of your CLL cell. But those antibodies have a little fluorochrome attached to them. So when they pass through a special machine called the flow cytometer, and a laser light is shone on this, the fluorochrome will refract or bend the light in a certain way, and then we can interpret that on a scattergram. So this is seen on the right of your screen there, and we know that CLL is usually positive for CD5, CD23, but negative for FMC7, and there's other markers that we put together. And that helps us be sure that it is indeed CLL and not another form of a lymphoproliferative disorder. If someone comes to me and the diagnosis of CLL is established, but they're otherwise asymptomatic, if their hemoglobin and platelet count is normal and the lymphocytosis is not particularly high, I might elect just to adopt active surveillance, and we'll come on to discuss why that's important. So not everyone necessarily will get a scan at the start, but certainly sometimes it's useful to have a scan as a baseline, and certainly before we need to think about any treatment, we will often organise a CT scan. and that helps us determine the stage. And there's 2 staging classifications, the Binet or the Rye classification. They both look at the number of lymph node sites involved, blood count and platelets, and then the Rye also takes in whether there's enlargement of liver or spleen. So we've touched on how someone might present, some of the tests you have at diagnosis, staging, etc. But what about genetics in CLL? And I think this is where sometimes things can become more confusing. The terms we use aren't always easy to understand, and they can be hard to remember. And I always would encourage patients to bring notepads and make notes, and always ask us questions about anything that you hear at the clinic that you don't understand. But as part of our practice, we will look at the genetics of your CLL, particularly if you need to embark upon treatment. And so just to clarify, these aren't things that you inherit or pass on. These are abnormalities specific to the CLL cell, and they are acquired. So all of our cells will have 46 chromosomes, and they come in pairs, so 23 pairs and a total of 46. And CLL, like all other forms of cancer, is often driven by genetic changes in the affected cell. And if we go looking for these, even at diagnosis, we will find them in the vast majority of people. There are different ways in which this can affect people. For some, it can be a deletion in part of the chromosome, and the commonest areas that we see these deletions are in chromosomes 11, 13, and 17. But sometimes you can see an extra chromosome that's called trisomy, and the commonest abnormality would be trisomy 12, so 3 copies of chromosome 12. Or sometimes there could be a switch in part of the chromosome, and that's called a translocation, and the commonest one in CLL will be between 11 and 14. In clinical practice, while we know that a lot of these abnormalities may be there, they may not necessarily change what we do. But what might change what we do is if there is a deletion on chromosome 17. That is important for us to know, and it can be a marker of prognosis. So certainly as part of my clinical practice, it is something that we will look for, and we would like to know if there is a deletion of chromosome 17. But in addition to a deletion of chromosome 17, it's also important to understand if there's any mutation in that area as well. The tumour suppressor gene is located on the short arm of chromosome 17. Its relevance in cancer was first detected in the late 1970s, but its importance in CLL was first recognised as far back as the 1990s. Deletions or mutations in chromosome 17 P are present in about 5 to 10% of people at diagnosis, so we can look for that at presentation. But certainly, as you live with CLL, if you go on to need treatment, a second, third, fourth, or further lines of therapy, we may look to see if it has been acquired, because while it may not be there at the start, it could develop down the line. And you may also be aware of IgHV. Again, not an easy term to remember. It refers to immunoglobulin heavy chain variable. So remember, we talked about our B cells making antibodies to help us fight infection. These antibodies are also known as immunoglobulins. And whether the gene, so an immunoglobulin is composed of a heavy chain and a light chain that come together, and whether the gene for the immunoglobulin heavy chain variable region, again a very long term, IgHV for short, is mutated or unmutated, can be looked at the start. That won't change, unlike T17P status or TP53 status, which can change and evolve over time. IgHV status doesn't, and we generally check that at the start, and it can either be mutated or unmutated. I'm happy to take any questions on that later on in the Q&A. So I know when we asked for a show of hands earlier, a significant number of patients in the room are under active surveillance. In the past, it used to be called watch and wait, but I think a lot of patients termed it watch and worry. It wasn't always the nicest term to use. So I think the preference is to refer to this as active surveillance. So about a third of patients who are diagnosed with CLL may never need treatment. Another third may not need treatment at the start, but will go on to need treatment in their lifetime. Watch and wait is still important for many patients, and I'll come on to explain that in the next slide. But watch and wait or active surveillance can vary from patient to patient. For some, it's self-directed monitoring. For some in our practice, it's through our nurse-led clinics. Others, it's through consultant-led clinics. And I know Laura's going to touch on how you can try and live well during the active surveillance period in her session. But surely active surveillance goes against the grain. All of the news out there is about early diagnosis and earlier intervention, catching cancer early. So why on earth would you come to a haematologist to tell you you've a chronic leukemia, a blood cancer, but not do anything about it? And no, Nicky sort of referenced that in his patient reflections. So To date, there is no evidence that earlier intervention in patients with CLL is of benefit. And the most recent trial to look at this was this trial called CLL 12. This was a large international trial. It was led by the German CLL group, and it looked at patients who had early stage CLL, so Benét A. But there were patients who were deemed to be higher risk of progressing at an earlier point. And these patients were randomized to receive a relatively new drug called ibrutinib. This is a BTKI, Bruton tyrosine kinase inhibitor, or placebo. And when these patients were followed up, what we did see was that ibrutinib did increase the time to when patients became symptomatic from their CLL. So you think, well, actually, that's a good thing. Maybe we should intervene earlier. But in the longer term, there was no survival benefit. So in the longer term, it wasn't felt to be of benefit to expose patients to the drug ibrutinib at an earlier point. And certainly patients were experiencing side effects, and we've heard earlier about some of the side effects of BTKIs. They can cause easy bruising, high blood pressure, and an increased risk of atrial fibrillation. So the conclusion from this trial was that as it stands in 2025, active surveillance is still appropriate for patients who have earlier stage disease. There is another trial currently underway at present called EVOLVE, and it's looking at other targeted therapies, obinutuzumab and venetoclax, which we'll come on to discuss, and whether or not intervention with these agents may or may not be of benefit. So if active surveillance is appropriate for certain patients, when is it the time to start? Well, we will explore lots of things when we review at the clinic, but we work with the International Working Group CLL guidance, and they have 6 indications of when we think we should start treatment. So if your hemoglobin is falling, and that's perhaps because there's a large burden of CLL in your bone marrow or causing your spleen to enlarge, or again, if your platelet count is falling for the same reason, those might be indications to start therapy. If your lymph nodes are increasing, or if your white cell count starts to rise very quickly, and we often talk about a doubling time of less than 6 months, but usually the absolute value has to be at least above 50. We heard from Nicky, who reflected on his history of ITP, and some patients may develop ITP or autoimmune hemolytic anemia. These are immune consequences of CLL, and they can be driven by the CLL. So if you're breaking your platelets down too early or breaking your red cells down too early, sometimes you can try strategies to bring those under control, but if those don't work, there is then an indication sometimes to bring the CLL under control in order to bring these immune complications under control. And then we talk about these B symptoms, the unintentional weight loss, the significant fatigue, fevers or night sweats, and again, sometimes those might be indications to think about therapy. So where are we with treatment options in 2025? Well, a lot of things have to come into consideration when choosing optimum therapy, and the most important at the top has to be your patient preference. There are different options and different strategies, and it's our job to try and discuss the pros and cons of the options and the strategies, understand what fits you best. But I do have to take into consideration things like your fitness and other medical problems and any other medications that you're on, because some of the drugs that we use can interact with other medications, so some may not necessarily be safe to use. When we do need to think about starting therapy, deletions or mutations in chromosome 17 are very important, and if they are present, we may choose to treat you slightly differently to other patients. IGHV status can give predictive factors, and again, it may influence the choice of therapy. But also then there may be issues about drug availability and clinical trial options, and certainly would encourage you, if there are any trial options available to you where you attend, it's always something worth considering. I think patients who are enrolled in clinical trials often do very well. There's a lot of extra help and support for patients in trials. Certainly my practice is NHS based, I don't do any private practice, so what I can do sometimes is dictated to me by NICE and by NHS. I think the take-home messages today are that treatment options in 2025 are extremely effective, and I did try yesterday whether I should take the generally well tolerated out. It's easy for me to say, I'm not the one having to take the drugs, but I think as someone who's worked in haematology for quite some time now, I do think the evolution of therapy has moved into a better tolerated place than it was maybe some years ago. But there are different options available, and when it comes to deciding, I think there's lots of factors that you and I would have to take into consideration, and it should be a shared decision-making process. So let's explore some of the options in the current classes of drugs available to us. So we've got three broad classes here. Proton tyrosine kinase inhibitors, of which we have three here. Ibrutinib, which was the first generation, and now we have second generation acalabrutinib and zanubrutinib. BCL2 inhibitors, of which we have venetoclax, and we've heard some of these names mentioned this morning. And then we also have monoclonal antibodies, obinutuzumab and rituximab. They really don't make the names easy. As well as having different classes of drugs, we often have different strategies as well. Some of these drugs are given continuously, such as the BTKIs, acalabrutinib and zanubrutinib. They're given in the longer term. But there are also fixed duration options, and certainly in my NHS practice, first line, I have the options of obinutuzumab and venetoclax, and also ibrutinib and venetoclax, and we'll explore these in a wee bit more detail now. This timeline shows how CLL therapies have evolved. In the latter half of the last century, we used chemo drugs, chlorambucil, cyclophosphamide, and fludarabine. The drug rituximab first became available in the late 1990s, and this really revolutionised the treatment of both CLL and other types of B-cell lymphomas. And really, it was with the addition of rituximab that we actually first started to see significant falls in mortality associated with CLL and other B-cell lymphomas. But even in the early 2000s, that was still an era of combining rituximab, which is a form of immunotherapy, with chemotherapy, and that was the era of chemoimmunotherapy. But certainly probably since about 2014, 2015, we are moving into an era of targeted therapy, and you can see the drugs that we've mentioned, ibrutinib, venetoclax, acalabrutinib and zanubrutinib, all becoming available in recent years. So we've mentioned these drugs, proton tyrosine kinase inhibitors. Well, how do they work? The simplest way to think about them is that they block how the B cells talk to each other, how they signal each other, and if you can block that signal pathway, you can bring CLL under control. So B cell antigen receptor signaling is required to allow the CLL cell to grow, to expand, to proliferate. And part of that is the proton tyrosine kinase. That's an essential element of this BCR signaling pathway. So drugs that bind to this and block it will allow switching off of those signals and allow the cell to undergo a medical term called apoptosis, which is programmed cell death. CLL, like other cancers, for some reason the cells should naturally come to their end and should die, but for some reason they lose this programmed cell death. And switching off this B cell signal allows the CLL to come under control. These drugs are tablet-based, they're continuous, you can take them at home. For most people, they are generally well tolerated, but we have touched on some of their side effects. Certainly, we can see more easy bruising or bleeding. We can see an increase in incidence of high blood pressure, and some drugs can also increase the rate of atrial fibrillation and irregular heartbeat, and we've heard about that earlier today. So the first generation was ibrutinib, but we now have second generation drugs, acalabrutinib and zanubrutinib. And this is one trial that compared acalabrutinib to ibrutinib. This is the ELEVATE-OR trial. And what this trial was trying to do was show that acalabrutinib was just as effective as ibrutinib, so it's called non-inferiority. And it did indeed show that acalabrutinib was just as effective as ibrutinib at bringing CLL under control. And this was patients who had had more than one treatment already. But what this trial did show was that there were less side effects with this second generation BTKI. You see the light blue is the acalabrutinib line, and there are lower bleeding events, lower incidence of diarrhea, less joint aches and pains, and importantly less incidence of atrial fibrillation and high blood pressure. Zanubrutinib is the other second generation BTKI, and this trial was called the Sequoia trial, and it compared it to chemoimmunotherapy, bendamustine and rituximab. What this trial was able to do was show that zanubrutinib was superior to chemoimmunotherapy. And again, there's several other publications which will show that zanubrutinib has less side effects than ibrutinib. So that's our BTKIs. How does venetoclax work? Well, it's a different drug and a different class of drug. It is a BCL2 specific inhibitor. And what it does, it allows the release of this pro-apoptotic protein. So apoptosis is programmed cell death. By binding to BCL2, you get the release of this protein, and the cells are then able to undergo their programmed cell death. Very effective and a very potent drug. And often in practice, it is given in combination with a monoclonal antibody or an immune therapy, of which obinutuzumab is an example. So we mentioned earlier that the B cells have little proteins on their surface, and we know that in CLL the B cells will have CD20 on their surface. Obinutuzumab is able to bind to CD20, but you'll see there at the top it's the red molecule and has two arms. Its other arms are able to bring our healthy white cells or macrophages and NK cells to the B cell and allow those to then attack and destroy it. So you're hitting the CLL in different ways with BCL2 and with the immunotherapy. Sometimes a problem that can occur with venetoclax is the risk of tumour lysis syndrome. The drug is so potent and so active that it can break the cells down very, very quickly. So we have to be careful that we protect your kidneys and don't cause any harm from these drugs. Many patients will receive allopurinol, fluids, or there are other strategies to try and protect your kidneys from the breakdown products of the cell. These include chemicals such as uric acid, potassium and phosphate, and these could be potentially harmful to kidneys, so we have to manage this accordingly. In the past, we have had various strategies to reduce the risk of tumour lysis. It often involves starting a small dose and over a course of about 5 weeks, ramping up to bigger doses. And there are some strategies now looking at more rapid escalation, and we're actually about to pilot that in our hospital in the coming weeks. And this is just an example of the CLL14 trial, which looked at this combination of drugs, venetoclax and obinutuzumab, comparing it to another option of chemoimmunotherapy, and was able to show that this was a very effective strategy in the frontline setting. So how does this differ to these sort of fixed duration therapies? How do they differ to continuous BTKI? Well, often obinutuzumab and venetoclax is often given for a block of 12 months. In my NHS practice, I also have the option of ibrutinib and venetoclax for a smaller percentage of patients, and that's more of a 15-month block of therapy. Here you have a combination of a drip and a tablet. It's much more intense at the start, particularly in the first 8 weeks. There's lots of visits to the hospital. There are risks of infusion reaction related side effects to the obinutuzumab, and that's not pleasant. It can often involve a temperature or low blood pressure, but generally you're very well supported by a clinical team who can help overcome any of these infusion related side effects and the management of the tumour lysis. And in the longer term, these drugs can cause low blood counts, in particular low white cells, and venetoclax can increase the risk of diarrhea as well. So you see, it's quite complicated space, lots of different drugs, different strategies, and it's not always easy to make this choice. Thankfully for most people with CLL, when it comes to needing treatment, we sometimes have a wee bit of time to think about things, time to allow you to explore what the options are, see what meets you and your needs, what is your preference, bearing in mind those other things like other medical problems, other medications, certain factors about your CLL. Some drugs may fit it better than others, but we need time to consider this, draw on support from resources that we've discussed today and from your clinical nurse specialists, and of course us as your haematologists. And just to say that sometimes when there's a choice at the start, and if we're able to have choice at the start, often if we need to think about therapy further down the line, if you don't get exposure to one of these drugs at the start, usually down the line we can sequence the drugs in a certain way that they may become available in second or third line, and we'll maybe pick up on that later in the afternoon. And just to say that it is an exciting time. I showed that timeline where things have really changed and expanded, particularly since about 2014. There are other combinations of BTKI and BCL2 currently being studied. There are new generations of BTKIs, they're called non-covalent drugs, pirtobrutinib is an example, and a whole new set of drugs called BTK degraders. And there was a mention about MRD earlier, and certainly there may be a role in detecting or sort of undetectable levels of disease, very deep responses, and whether that can drive our therapy in the future. So lots of work is being done in the trial space. We're constantly learning and evolving practice all of the time. And really I hope that the take-home message from my talk is that there has been significant evolution. We have very good options in 2025, and when it comes to thinking about treatment when the time is right, hopefully we take into consideration your preferences and your needs and have a shared decision-making process.